Next, we'll look at anxiety disorders. We'll look at generalized anxiety disorder, then panic disorder, post-traumatic stress, and obsessive compulsive disorder. So by definition, anxiety is defined as a state of apprehension, terror, fear in response to an external threat. The Latin word angere means to choke or strangle, and that's often the sensation people have, is a choking or a tension sensation in the chest. We'll come back to the differential, but it's always important to differentiate anxiety from an organic cause such as a heart attack or angina or hypertension, pulmonary embolism, etc. As many as 44% of Americans reported to suffer from anxiety disorders, so that is a very large percentage of the population. Now, this doesn't mean all these patients need to be medicated for this, but that's something that needs to be addressed through all the different techniques that we have. Anxiety disorders are characterized by intense emotions, so fear is a typical one, foreboding, dread, impending doom, irritability, which again, in Chinese medicine thinking, this relates us to the kidney system, which is tied in with the adrenals and adrenal responses. There are physiologic changes, so this is not just emotional changes, but also direct physiologic changes, rapid heartbeat, increase in blood pressure, chest pain, hyperventilation, tremors, muscle tension, dizziness, tingling, sweating, etc. All of this really suggests overactivation, as you can imagine, of the sympathetic nervous system. So overactive sympathetic nervous system with overactive norepinephrine, and then from the adrenal medulla, overactive epinephrine, that's a hormone in the blood. So all that will cause your blood pressure to go up, your heart to beat faster, maybe have skip beats, etc. Sensation of choking, loss of appetite. That's generally because in the altered sympathetic response, it's going to shut down all the parasympathetic responses, the rest and digest responses. So the body says, we're going to need to deal with this threat or perceived threat before we can put energy towards digestion. There's a pronounced startle response and sleep disturbance. So along with the sympathetic nervous system, huge changes in the HPA axis, and that usually results in elevations of cortisol or disturbed cortisol rhythm, etc. So that would be some physiologic changes. Changes in thinking, so thoughts tend to speed up or slow down. There's unusual perceptions of light, sound, and reality in general. And anxiety disorders can be accompanied by panic attacks. And so that's anxiety with intense fear, often a fear of dying. There's physiologic changes with rapid heart, thumping palpitations, head pressure, chest pain, difficulty breathing, shaking. The hyperventilation can cause reduced carbon dioxide, so the blood actually becomes more alkaline, and that can result in muscle spasms, numbness in the extremities, dizziness, confusion. And that's why during a panic attack, we sometimes have patients breathe into a paper bag, and then they can recycle that CO2, so that maintains their blood, a proper pH balance in the blood. Anxiety is pathological when the reaction is really out of proportion to the severity of the threat, and it really begins to interfere with the activities of daily living. According to the biopsychosocial model, the kind of thought here is that neurophysiologically there's an overactivation of the amygdala. Remember, that's our fear center in the limbic system, the HPA axis, and the sympathetic nervous system. So we have increased norepinephrine, usually increased cortisol, and then decreased GABA and decreased serotonin. And as we'll see, the primary treatments for pharmacologic treatments for anxiety either address serotonin or GABA. Different drugs and medications we know can trigger anxiety in people. So alcohol, stimulants, obviously, caffeine, organic solvents. And there are 5 major types of anxiety disorders. So there's generalized anxiety disorder, GAS, panic disorder, obsessive compulsive disorder, phobic disorder. It could be social or any particular phobia. That could be like fear of spiders or being out in public. And then post-traumatic stress disorder. And each of these have slightly different treatment approaches. So the screening tool here is generally GAD-7. So GAD-7 is the screening tool for anxiety disorders. This is a 7-question questionnaire that the patients can fill out, and they can give us the sense of, is anxiety a concern here, and how severe is it? So it quantifies it a little bit more for us clinically. and then there are DSM-5 criteria I'll go over here with each of these anxiety disorders. The treatment's going to vary depending on the type of anxiety, and we'll again use the therapeutic order based on the severity. So let's talk about generalized anxiety disorder, GAD, first. This is excessive anxiety about various aspects of daily life, nothing in particular, just life in general, causing severe impairment in a person's activities of daily living. So it's nonspecific, persistent fear and worry, over concern with everyday matters. The lifetime prevalence is about 5.7%, and it affects more women more than men, 2-to-1 ratio here. 2/3 of patients with GAD have major depressive disorder as well, or another anxiety disorder like a specific phobia or maybe a history of PTSD. And the symptoms usually begin again early in life, around age 20. The diagnostic criteria, according to DSM-5, is excessive unremitting anxiety for more than 6 months, about a number of events or activities, and again, severely impact ADLs. So person finds it difficult to control the worry, and the anxiety has to be accompanied by at least 3 of the following. So feeling of being on edge, fatigue, difficulty concentrating, irritability, poor sleep onset or maintenance, and muscle tension. So we look for anxiety for more than 6 months with at least 3 of these accompanying symptoms. And of course, doing a proper differential diagnosis so that we have ruled out all of the medical conditions, potential for substance use and abuse, other medications, etc. The treatment, again, address level 1 through 3 of the therapeutic order, CBT. The main pharmacotherapeutic approaches would be to use SSRIs first. Now, it used to be that patients receive benzodiazepines first, but as we talked about, benzos have a very high rate of dependence and tolerance, and so there's sort of a shift away from using those, and the current guidelines are to start with SSRIs, potentially SNRIs like the Effexor. And then buspirone, that's slower acting, takes about 2 weeks to take effect. But that works on the GABA receptor through a different mechanism. It doesn't have the dependence and tolerance of the benzos, so that's another medication some patients are given for anxiety. There are some antihistamines that are given as well. Hydroxyzine, you might see patients on that. This is one, it's called Vistaril. This is very commonly prescribed for patients where it's not clear to the doctor what's happening, but clearly anxiety is a huge component. They meet some of the criteria, but instead of giving SSRI, they might give this hydroxyzine, which is actually an antihistamine, but it can be very sedating, very relaxing, can help patients get better sleep. And I've had a number of patients really say they really benefited from the hydroxyzine. So that might be a medication you see anxiety patients on. Okay, so that's a little on generalized anxiety disorder. Let's look at panic disorder next. That's anxiety with panic attacks. And usually these attacks occur 2 times or more per week. The specific causes of panic or panic attacks are unknown, but there is a strong genetic component again, maybe up to 30% of causes. We know that autonomic dysfunction is common, for example, elevated sympathetic stress and elevated HPA axis. Really chronic consequences, worry about future attacks, there's significant changes in behavior, hypochondriasis, and so forth. And they can be present with or without agoraphobia. So that's something to think about. And again, agoraphobia is extreme fear of being in a place where escape is difficult. That's now considered a separate diagnosis in DSM-5. So there used to be agoraphobia was part of panic disorder. Now they've separated that out. The diagnostic criteria are anxiety with panic attacks on a regular basis, and that's having 4 or more of the following symptoms. Less than 4, by definition, is considered a limited panic attack. I know this gets really technical, but just to give you a general feel for kind of the criteria, and that's having palpitations, pounding heart, increased heart rate, sweating, trembling, shaking. Again, a lot of sympathetic activation symptoms, shortness of breath, feeling of choking, chest pain, discomfort, nausea, abdominal distress, dizziness, lightheadedness, feelings of unreality, feeling of being detached, fear of losing control, going crazy, fear of dying, paresthesias, and hot chills, hot flushes. So it's not just the mental, psychic aspects, it's also physiologic aspects as well. At least one attack is followed by 1 month of a person fearing they will have another attack, causing avoidance behavior, like not going into certain places because of it, and it's not explained by another disorder, like a specific phobia or medical condition, or again, substance use or abuse. The treatment here biomedically would be relaxation therapy, CBT, usually combined with that. And then the kind of first line of approach would again be SSRIs. That's the first line, especially if there's agoraphobia. Tricyclics and MAOIs are often used too for panic disorder. And then sometimes benzodiazepines, but again, we're really trying to de-emphasize benzos because of their negative effects. So that's panic disorder, or PD. So obsessive compulsive disorder, or OCD, is repetitive obsessions, and that's distressing, persistent, intrusive thoughts or images, or compulsions, urges to perform specific acts, and the process is entirely illogical and inexplicable. The patient realizes, so this is important, they realize that their thoughts are the product of the mind and are inappropriate, and we call that an ego dystonic effect. We'll see later in personality disorders, especially what are called cluster C personality disorders, and there's something called obsessive compulsive personality disorder. These are ego syntonic. The patient actually doesn't understand that these thoughts are not healthy, and they don't have that awareness that these obsessions and compulsions are coming into consciousness. But all patients with OCD are ego dystonic. They have an awareness of these that these thoughts, these compulsions are not normal. The incidence is about 2 to 3% in both males and females equally. So 2 to 3% of the population. And the causes, again, genetics. There's a connection with the family history of Tourette's syndrome, serotonin imbalances, different psychosocial factors, and then often this is triggered by specific stressors. A sort of version of OCD is body dysmorphic disorder, BDD, and that's a preoccupation with a minor or imagined defect in appearance. There's usually significant emotional distress or impaired functioning, and patients often repeatedly seek cosmetic treatment. So these are patients who might show up frequently to the plastic surgeon, or they want Botox and all these things, kind of just really too often, more than the average person maybe. And so that's always something to think about. Is this a version of OCD in that patient? So the DSM-5 criteria include the symptoms of obsession and or compulsion. Again, the symptoms are ego dystonic, and there's significant impairment in the ADLs. And the treatment is, again, CBT is the most common, and then pharmacotherapy, usually SSRIs are the first line therapy for compulsions. Say from a more traditional perspective, the digestive system is certainly something we look at. And again, I linked earlier serotonin with the pancreas, with the so-called spleen organ network in Chinese medicine. So that's always something to look at. But I also see a high correlation with lung and lung rhythmic imbalances. So the metal imbalances would be something to look at as well. And that ties in, interestingly, with thyroid. And so looking at a person's thyroid function might be something that could be important here. So that's obsessive compulsive disorder. Phobic disorders, there's many different types. There's agoraphobia, as we mentioned, social anxiety disorder, arachnophobia, etc. Social phobia is extreme fear of social situations in which the individual has to interact with unknown people or is subject to scrutiny of others, like standing in front of a crowd and having to give a little talk. And that results in potential embarrassment or humiliation. So social speaking, even using the washroom, it affects men and women equally. And then there are specific phobias. Those are extreme and irrational fears around a specific object or situation. These are more common in women, and the objects and situations commonly elicit of phobia include things like situational, being in closed spaces, animal, insect, environmental, like cats, spiders, and heights, and then other things like getting injections or having blood drawn, things like that. For social phobia, the DSM-5 criteria, again, intense fear that's triggered by social situations in which the patient might be humiliated or embarrassed. Anxiety response is immediately elicited by the situation. Patient is aware that his/her reaction is excessive, and the patient goes to lengths to avoid the situation. And then specific phobia would be the symptoms similar to the social phobia, but the exception here is the intense fear is triggered by that specific object or situation. So for social phobia, the first line treatment again is SSRIs. Paroxetine is Paxil is one example of first line therapy there. Tricyclics, clomipramine, and then beta blockers might be used for acute situations. These block the effects of the sympathetic nervous system, remember, and so they might be helpful for public speaking or performance or things like that. And then cognitive behavioral therapy, doing visualizations, kind of going through the imagining the situation, and then sort of learning how to regulate those stress responses that arise from those images can be part of the treatment as well. So that's called exposure desensitization therapy. So sometimes they'll actually, for specific phobias, gradually have a person visualize, let's say if they have a fear of spiders, visualize being in a room of spiders, or at least seeing a spider at a distance, and then gradually increasing that. So they imagine themselves maybe in a room of spiders, and they learn how to regulate their stress responses. And then they might actually bring a spider in, and that might be towards the end of the therapy, but eventually then the patient learns how to overcome a lot of those fear responses. So that's phobic disorder. Post-traumatic stress disorder, or PTSD, is anxiety disorder resulting from a traumatic experience, and that could be combat, sexual, or physical abuse. The patient continues to relive the memory, so there's hypervigilance, flashbacks, avoidant behaviors, anxiety, anger, depression. It can be preceded by an acute stress disorder, so anxiety symptoms occurring within 1 month of the trauma and lasting less than a month. So usually there's a temporary anxiety, and then later down the road this becomes PTSD. Again, if the symptoms are more than 1 month, then PTSD is diagnosed. About 30% of patients undergoing acute trauma go on to develop PTSD, so that's a very high percentage. And then patients are at greater risk of developing depression and substance abuse. So the criteria is that the patient has witnessed or experienced a situation in which they felt their well-being or the well-being of others was threatened. And that's accompanied by feelings of extreme fear and helplessness. Patient continually relives the experience through recurrent thoughts, dreams, through objects or situations that symbolize or represent an aspect of the traumatic experience. Patient goes to great lengths to avoid anything that will trigger the anxiety. And again, these are all be things you might see elicited in the history of the patient. Emotionally detached, they're restricted affect, there's increased arousal, so difficulty sleeping, hypervigilance, difficulty concentrating, maybe bursts of anger or irritability, and then daily functioning severely impaired by the anxiety. And the symptoms present for at least 1 month. So those are all the DSM-5 criteria for PTSD. The sort of typical treatments would be exposure therapy. That's the treatment of choice. So that would be, for example, if there's specific triggers or stressors, would be to, again, go through the visualization process with that and desensitize patients to that. Relaxation therapy, so just general relaxation, not specifically around that stressor. Support groups and psychotherapy, those could all be offered. The pharmacologic approach would be SSRIs, MAOIs, TCAs, like the imipramine and amitriptyline. And then benzos for acute attacks are not, that's more commonly given there, and they're usually used just short-term, Ativan or Xanax. And then anticonvulsants and another drug called prazosin, which works in the central nervous system to really downregulate your sympathetic nerve response, and that's especially for nightmares and flashbacks. So I've seen patients that have been diagnosed with PTSD pretty much on the whole variety of medications here. And again, they're not going to be on all of these, but usually one, maybe a combination of two. All right, so that's post-traumatic stress disorder. Now, since sleep disorders often go hand in hand with anxiety disorders, I'll just say a few words about sleep disorders. This is important because, I think a very large percentage of our patients, I'd say probably more than 60% of my patients, report some type of sleep disorder. And that's either not being able to fall asleep, that's sleep onset problems, or sleep maintenance, they can't stay asleep. And so clinically, we always try to quantify that a little bit more. We try to see where the issue is, and then we try to look for underlying medical conditions and so forth. But we basically try to categorize their specific type of sleep disorder. So the most common one by far is primary insomnia, and that's problems falling asleep or staying asleep. It occurs usually at least 3 or more times a week for at least 1 month. And this is very common, affects up to a third of the general population. And then it perpetuates because people feel anxious now about not getting enough sleep. So the treatment for this is biomedically, there's not a lot of good options. And so a lot of patients I find come for adjunctive care for this. Here we really do want to address levels 1 through 3 of the therapeutic order, maintaining sleep hygiene, but even looking at things like anti-inflammatory diets, getting proper exercise. These are all super important. Avoiding excess alcohol or caffeine, all of those make sense. Same with cigarette smoking. All of those obviously would contribute to poor sleep. This is where blue light exposure before bed, blue light has a wakening effect in the morning, but in the evening it can actually suppress your melatonin secretion, and so we want to avoid blue light therapy in those cases. So those would be all the typical recommendations. There are a lot of different micronutrients that we can use for sleep, and all of those are ones that tend to increase GABA, or serotonin. Serotonin, remember, is the precursor to melatonin. 5-HTP is a good example. This is a precursor to serotonin, and then so that converts to serotonin, and then in the pineal gland, through 2 steps, it converts to melatonin. There are the enzymes in the pineal that can do that. And it turns out that the melatonin can help induce sleep. It doesn't help you stay asleep. That's really the role of GABA, is to help you stay asleep. And so people with poor GABAergic signaling have issues with that. Taking melatonin, interestingly, there's some question about the melatonin. Number one, if you take more than a milligram of melatonin, that could potentially suppress your endogenous melatonin rhythm. But the other concern is really the melatonin we're looking for is melatonin that gets into the cerebrospinal fluid across the blood-brain barrier. And as far as we know, taking melatonin orally does not get into the CSF. And so we want the pineal gland doing that job for us. Giving 5-HTP, we think, gives a substrate that helps the pineal make more melatonin. Also, vitamin B6 and zinc are needed as part of this synthetic pathway. So these are often found in different sleep blends. There are a lot of different herbal therapies: passion flower, skullcap, valerian, melissa. In Chinese medicine, we use jujube, the xuancao ren. There's albizia, which is another very important anxiolytic, but also helps for sleep. These are a lot of the therapies I find that for by far the majority of patients, well over 85%, they're effective. And so we often don't need to go to the heavy hitters. But for some patients that need to jump to level 4 therapies, some things that are commonly used, I'll mention one, and that's diphenhydramine, which is Benadryl. That actually is not in the treatment recommendations for insomnia. We know it has a lot of adverse long-term effects. I do see a lot of patients self-medicating on this, and really that should be discouraged. So we want to try to switch them to something else. The Z drugs, which we talked about in the drug section, would be the major drugs used here. So zolpidem, the Ambien, Zaloplan, Sonata. These have a significant high risk, though, of lots of sedation, grogginess the next day, and so forth. So these are drugs that maybe have a role short term, but we certainly want to try to transition patients off of them if we can. It can be very difficult to do it for long term. And then trazodone is sometimes used for short term, addressing sleep issues. So that would be kind of some typical approaches for primary insomnia. Primary hyperinsomnia would be excessive daytime sleepiness or excessive sleep for at least 1 month. Often this is in adolescence, you see this a lot. If it needs treatment, the first line therapy, again, I would look at levels 1 through 3 of the therapeutic order, but the biomedical approach would be to use stimulants, the amphetamine-like stimulants like Ritalin and so forth, and then potentially SSRIs. Narcolepsy, I'll just say a few words about that, and that's sudden sleep attacks, so they're repeated during the day for at least 3 months. Patient is just normally awake, they're doing whatever they're doing, and they have cataplexy. They have a sudden collapse while awake, they have loss of voluntary muscle tone, they have short REM latency, and then they have what's called sleep paralysis. hypnagogic and hypnopompic hallucinations. So that has to do with the reticular activating system going offline. So it's almost like your RAS, which normally is in the brainstem, remember, and that normally is inducing wakefulness and consciousness. It's like it just turns off. This is uncommon, fortunately, but it can be very severe and devastating for the people that have it. Onset usually is early in life, childhood or adolescence. We think there might be some genetic associations with norepinephrine, dopamine, and histamine. And then the treatment is often trying to figure out, can we integrate scheduled naps for a person? But the main treatment would be using stimulants, amphetamines, methylphenidate, the Ritalin, etc. SSRIs could potentially be used for the cataplexy as well. So I have used precursors to norepi and dopamine. Remember, dopamine comes from norepi, and L-DOPA is the precursor to dopamine. So giving L-DOPA, the velvet bean plant, Mucuna pruriens, has a lot of DOPA. That's again used for Parkinson's disease. That's something I have tried in patients with some success, but also just giving tyrosine. That is the amino acid precursor. This synthetic pathway requires iron again and B6. So we would look at all of that as potential nutrient things to replace. So I would again usually try to address levels 1 to 3 of the therapeutic order. I'll say also hormonally, thyroid, overactivation of the stress axis, all of those can contribute to narcolepsy. Circadian rhythm sleep disorder, this is a disparity between the circadian sort of light cycle. So a person really is shifting their sleep. So this would be a classic example, jet lag. But patients that actually have no impulses coming in from their retina, so they're blind and they don't have any retinal nerve signaling. The cells that sense the blue light, again, are in the retina. They're called ganglion cells. And if those impulses are not going to the brain, especially to the suprachiasmatic nucleus in the hypothalamus we talked about, then the circadian clock is not reset. So it's exposure to that blue light every morning that actually sets us to a 24-hour rhythm. And if you're not getting that light impulse to the eyes, then your clock's going to be shifted. So we see this often in patients who are blind, but also patients who work night shifts, a very distinct shift in their sleep. So there's usually, if it's jet lag or whatnot, it will recover usually within a week. This could be helpful to use light therapy, especially for shift workers. So whenever you decide dawn or the beginning of the day is, that's when they expose themselves to blue light for at least 20 minutes at that time. Of course, there are different acupuncture protocols that are used to sort of balance the energy in the meridians. I won't go into that here, according to the time clock. And then melatonin could be given, again, a few hours before you expect to go to sleep. So if you normally get off your night shift at 8 a.m., you might take your melatonin an hour or two before that, and then by the time 9 o'clock rolls around, you try to get your sleep. That said, there is an unfortunate thing that happens with people who do night shift work. That's totally messing up your hormone cascades and everything internally. Even if you're getting a good 8 hours of sleep somewhere during the day, if it's not synchronized with the light cycle, we find there's actually a higher risk of things like cancer. And we think that has to do with lower levels of melatonin, which is a very potent antioxidant to the brain and other tissues. And so the World Health Organization has actually classified night shift working as a known carcinogen for that reason. It's difficult, though, if the patient's livelihood depends on that. We have to sort of work with them to see what we can do to support them. Sleep apnea is the last one I'll talk about here, and that's abnormal sleep ventilation. So this is where the patients wake up at night gasping for breath. They usually don't wake up to the point that they are aware of waking up. And so maybe it's their spouse or partner in the bed who sees this, where they actually stop breathing, and then they sort of wake up, take a gasp of air, and then they breathe a few more normal breaths, and again, it's like they stop breathing, and then they gasp again. That's sleep apnea. And it can be due either to obstruction in the nasal passages or whatnot. That's called obstructive sleep apnea. And that has to do with airflow problems with the palate and with the nasal mucosa. Or central, which is more of a brainstem issue. Both of these, and sometimes you could have mixed forms, and they both lead to sleep disruption, excessive daytime sleepiness. So for patients who come in reporting fatigue, we're always looking very closely at their sleep and at the potential for sleep apnea. Unfortunately, with sleep apnea, it's very common, up to 10% have this, often associated with obesity. But we also know, unfortunately, that sleep apnea is highly correlated with high blood pressure. In fact, we think it's one of the drivers of high blood pressure in some people. Usually there's a lot of snoring, especially with the obstructive sleep apnea. Much more common in males than females, 8-to-1 ratio. Central sleep apnea with the brainstem problems, there's a higher incidence in patients with heart failure or alcohol use, and it's more common in the elderly. And the main treatment, or the assessment really, is to send for a sleep study where the patient spends the night in a sleep clinic. They're hooked up to an EEG. They are hooked up to monitors to monitor their respiration, and this can give valuable information. So if you suspect that, that could be an important referral that needs to be made. The treatment for obstructive is to use a CPAP machine. This provides continuous positive airway pressure. There can be surgical techniques that can be used. I find addressing weight loss, the cardiometabolic pattern with their liver and heart disease, diabetes, all of that is crucial for long-term success on the sleep apnea. And then mechanical ventilation is sort of a down the road for more severe forms. But very common, and unfortunately with things like CPAP machines, they look like kind of a Darth Vader mask. A lot of people have hard time long-term using them, and so I find the compliance is very low. So if we can help them in other ways to improve their airflow and so forth, that can give them a lot of benefit. The last thing I'll talk about here is attention deficit disorder or attention deficit hyperactivity disorder, so ADD, ADHD. This is a developmental disorder. It's highly controversial. We, of course, hear that discussion that maybe a lot of kids being diagnosed with this actually don't have any problem, medical issue. They really just have, they learn differently, or they need a different learning environment to really properly develop and function. And so there's some controversy around that. That said, I have seen a number of children that have been diagnosed with ADHD, and they self-report issues. They talk about not being able to concentrate, and they constantly feel restless, and it's observable. I had 2 kids that were brought in by their parents. They were actually adopted from Russia, and we think they were actually, their parents were, the mother was using cocaine during pregnancy, and very interesting. These 2 kids, I mean, they were rail thin, very active, running around. They destroyed my office within 20 minutes. And this is an issue. This is something where the parents are at wit's end to try to understand how they can help them. So there is something that needs to be addressed in these children. So this is really where there are attention problems with hyperactivity and lack of impulse control. And usually this starts before the age of 7. If a patient just has the attention problems but not the hyperactivity, then the diagnosis is attention deficit disorder, ADD. This is pretty common. It's estimated up to 5% of children present with the criteria for ADHD globally. And it's chronic. It extends into adulthood in about 60% of patients, and that's just under 5 million Americans that meet the criteria for ADHD. Diagnosed more commonly in boys and girls, and again, the controversy, is this a true disorder or more reflective of our poor education system and social situation and so forth. We'll talk about nutrition here in just a moment. 3 types of ADHD. So the primary inattentive type. So this is the child who's easily distracted. They miss a lot of details. They forget things. They switch activities often. Poor focus. Easily bored. They daydream. They don't seem to listen when spoken to, and they have difficulty processing information. Then there's the primary, predominantly hyperactive impulsive, and that's the child who's squirming, fidgeting all the time, talking nonstop, dashing around, touching or playing with everything in sight. They have trouble sitting still during school or at home and dinner or to study. Constantly in motion, really difficult to be quiet. And then impulsivity would be impatience, blurting out inappropriate comments, They might show motion without constraint, and they can't wait for their turn, etc. And then there's a mixed type that has both these symptoms. And I think most of the children I've seen actually are more of a mixed type here. Often there's other disorders with ADHDs like persistent bedwetting, language delays, anxiety, depression, oppositional defiant or conduct disorders, that's antisocial disorders with temper tantrums, lying, stealing, deceitfulness. Borderline personality disorder we'll talk about later, obsessive compulsive disorder we already talked about, and bipolar. There's unknown causes. There's a lot of different hypotheses as to what's going on in these children. We do know genetics plays a role. I put 75%, that's coming from a couple of studies. There are a lot of gene polymorphisms looking at dopamine receptor genes. But I think environmental factors are huge. There's an interesting theory called the hunter versus farmer theory that, evolutionarily we didn't grow up fixed in a certain place. We were more hunters and gatherers, and so constantly in motion, moving, and our modern culture is more of a farmer, agrarian, or urban-based, culture, and so this is difficult for the hunter types to really fit into that role. And again, that involves polymorphisms, often with dopamine receptor genes. But environmental factors are being increasingly recognized here as huge. So alcohol, exposure to tobacco, smoke, fever, infection, but more and more realizing environmental toxins, organophosphates, pesticides, herbicides, Roundup, a lot of these mitochondrial disruptors, heavy metals, pollutants, plasticizers, you name it, we're exposed to it. And so we're really concerned now that's creating an underlying state of neuroinflammation. The brain is just chronically inflamed, and that's accompanied by things like overactivation of the immune system, maybe even autoimmunity, poor liver detox pathways, gut-brain dysfunction with overgrowth of unhealthy microbiome. So children getting a lot of antibiotics, that's changing their microbiome, that can change their brain function, and so forth. A lot of dietary factors with artificial sweeteners, high sugar diets, especially high fructose, corn syrup diets. The list goes on. But we probably have a multifactorial etiology here. And so clinically, it can be helpful to sort of tease through some of that and see what might be the most relevant things to address. Social family dysfunction, low arousal theory, and that's again involving dopamine, and then frontal lobe dysfunction. So we see a lot of these kids actually, if you do functional MRI, you find that the blood flow into the frontal lobe, which is your executive center, is diminished. So it's almost like the frontal lobe is in a sleep rhythm during waking consciousness. And so this is actually going to be where the stimulants are used. As I mentioned, the stimulants are centrally acting. They act on the central nervous system, and they actually increase activity in the frontal lobe. That sort of wakes the child up in a way so they now have their executive center online. They can suppress those abnormal impulses and so forth. The diagnosis here should not be made lightly. Really, it requires a full psychiatric assessment. Physical exam, imaging, lab tests are all used to rule out other medical conditions. So there's controversy about whether or not ADHD should be diagnosed by primary care physicians if it really needs excess specialty help. The reality is usually patients can't get in to see these other mental health providers, so they rely on their PCP to make the diagnosis and determine the treatment. There are DSM-5 criteria. You can look online at the diagnostic criteria. I won't go through that here. The condition is thought as something that could be managed. And there was a study in 2005 that looked at medication with behavioral treatment as being the most effective kind of treatment long-term. So behavioral modification with CBT, interpersonal psychotherapy, IPT, family therapy, maybe neurofeedback, which is measuring a patient's EEG and then taking those waveforms, inverting them, and then feeding them back as pulses to the scalp. And the idea is there it resynchronizes the brain. So that's becoming popular for a lot of different neurological conditions, neurofeedback. And then medication, the main pharmacotherapies would be the CNS stimulants. That's the medical treatment of choice. And so this is essentially modified amphetamines, so Ritalin and so forth are all used in that category. They all work with dopamine, so they're actually helping to keep dopamine more around in the synapses. Usually not recommended for preschool children. And the studies actually, I need to look recently, but we have to always look at, are the patients who are receiving these drugs, like a 6-year-old, have there actually been clinical studies showing that this is safe long term? And sometimes there's not. And it just has become common practice to give a medication. Now, the FDA has pretty strict guidelines on what is actually approved in terms of which groups of people, based on the clinical studies, can receive this, but that's not always followed in practice. So here again, we can look at things that maybe improve dopamine signaling, vitamin B6, zinc, iron, all those I previously mentioned, using the essential fatty acid like DHA. But increasingly, there's a lot of interest looking at the gut in these kids, cleaning up the diet, working with getting rid of all those potential additives in the food and so forth, working with the liver to improve the detoxification of metals and other compounds from the body, and then finally working with the microbiome as something. And that's something that there's actually some companies investigating, not as far as I know for ADHD, but for things like Parkinson's and whatnot. There's actually specific microbiota that are being developed as treatments. And so we might see that actually in the future with ADHD. So really that's where the level 2 therapies on the therapeutic order really come into play. Okay, so that's a summary of anxiety disorders. So know the different types of anxiety, what are the common diagnostic criteria and the treatment options that are often given, have an understanding of the drug classes, and again, you might want to review the pharmacology section we had on this. We looked at sleep disorders, and then we looked at ADD, ADHD. So understand, again, with sleep disorders, the different types of disorders, and then the criteria for ADD, ADHD, and what are some of the typical treatments used for that.